Good afternoon. I'm Richard Connect. I'm the director of the Children's System of Care, one person among many in Placer County that is responsible for the health and welfare and well-being of our 87,000 young people and their caregivers. Jim Nissen. Okay. Hello, can you hear me? Nope. Hold it down.
Hello, I'm Jim Nissen. I'm the fiscal manager for the Combined Systems of Care. We have two primary service divisions, our adult system of care and our children's system of care.
So we'll try to be as brief as possible. Condensing a 25-year journey into a few minutes is an impossibility, but some of the context I think will be important for you. We don't approach this conversation today from the perspective of responding to KDA. We have an integrated children's service that began in 1988 when one of our judges got tired of the social worker and a probation officer pointing fingers about who was responsible for the care to a particular minor and said, stop. He pulled the department heads together and said, you got to find a different way. And at that point, we began having a conversation about how to get in the same sandbox. Housed administratively within Health and Human Services, we're actually a blending of welfare, mental health, probation, health, alternative and special education, and community partnerships, all in a shared space with linked training, leadership, and information systems. And I appreciate, is there a clicker that we can advance now? Right over there, still loading. Awesome, thank you, appreciate that. So I appreciate very much Beth's education this morning. We are, I think, as close to that Madison model, although we're not hard capitated with our dollars. It's very similar to what that graphic was this morning with the Madison County model. We constructed the system of care without federal dollars. So back in 1988, there was no cooperative agreement, although I'll mention briefly, if we have time, how the cooperative agreement has evolved us significantly. I'm on the CSOC story slide now. Some key steps in our evolution involve a state waiver that I will say quickly as an aside, I don't think is necessary any longer. So if you're waiting for the state to give you authority or opportunity to play in the same sandbox with partners, I don't think it's necessary any longer. I think realignment and KDA and all sorts of other initiatives give you as close to explicit authority to be in the same sandbox and share revenue and information as you could possibly hope for. So let me just reference quickly, we had a pretty mature system of care when in 2005 we heard from our Latino, Native, and graduating, emancipating youth partners that we were not reaching an underserved and overrepresented populace in our county, and so we applied to the SAMHSA folks and got a cooperative agreement to basically relocate the locus of power and control from the government-centric system of care housed and held by the agency into the community. And it's been an interesting 7-8 years since. Today we have stakeholders from our Latino, Native, and youth and parent advocacy groups that are actually shared decision makers with the super agency that is the system of care. They come to our leadership meetings. They are co-located with us. They basically tell us where we are and are not succeeding. If we have more time, we can talk about that. Yeah, next slide. I'll come back to MHSA as the key sustainability element as we go forward. Yeah, give that one more click. So in a nutshell, the super agent, the system of care is administered by a designated superior court judge, the chair of the juvenile dependency bench, chief probation officer, the director of health and human services, and the superintendent of schools or her designee. We meet bright and early every other Wednesday morning and talk about how we can be better partners with one another. Next slide, thanks. I would suggest, by way of perspective, the system of care is not a new suggestion. If you look back at the Little Hoover Commission reports, at the Pew reports of the Presidential Commission, the Administrative Office of the Courts in California, we have for 35 years in this state been talking about delivering integrated care. And here we are, 35 years down the road, still struggling to close the gaps for families and youth. I'll say as an aside, I think in October of 2011, the state took a quantum leap backwards when we divorced ourselves from the Student Mental Health Initiative and assigned designated authority to schools to deliver mental health services to kids. AB 3632 was difficult. It was hard, but we have taken a big leap backwards by divorcing those dollars from the sandbox, taking them out of the collaborative. I'll say there are other initiatives that argue for integrated care. The Child Welfare League has a brand new Blue Ribbon Commission document out that speaks to the need for integrated care at the national level. And if you're in the child welfare or probation arenas, you know there's a conversation emerging around sexually exploited minors. These youth are our youth as well, and we will not serve them well if we're fighting about whose door they should come through or who should pay for their mental health care. So in a traditional service structure, you know, this is kind of how we look in most places. The Placer approach is, next slide, thanks, just a little bit different. Just a simple graphic for you. So real quickly, because I want to get to the fiscal stuff and give Jim a chance, because I know that's what most of you have come to hear about today. Let's go one more slide then, if we can. Integration, we've learned over the years, really has to be defined if you're going to talk about it effectively. There's functional integration, which I would characterize as being kind of in the same, with the same sand and the same toys, but you're kind of in different boxes. So your sandbox is like next to the neighbor kids, and you may toss toys back and forth sometimes, and you may step in and out of each other's sandboxes. That's different than being structurally integrated, where there are multiple agencies, including private partners, co-located, and sharing the same sand, same box, same toys, one large sandbox. To make that work, of course, you have to have fiscal integration, where the dollars from various funding authorities are all blended and braided together, and that's partly what we've come to talk about, I think, this afternoon. So I'm going to wind up here and then yield to Jim to talk about some money. But what we've learned in Placer over the years is that collaboration helps uncover natural resources that foster sustainability for both public and private partners. Those resources are not visible until people come into the sandbox together. And then you discover that you can leverage places that you didn't know you could before. And it takes time. You have to invest in those conversations. But we have today in Placer 4 or 5 nonprofit organizations that did not exist 10 years ago, and they're funded not solely with public dollars. And we wouldn't have known that those agencies could birth themselves and be great co-located, embedded partners with us if we hadn't had the conversation. Good collaboration shares risk between agencies, and most importantly, it fosters a power with instead of a power over. I'll never forget the experience I had a few years ago sitting in a large community collaborative in Placer, and one of the brand new executive directors of the Sierra Native Alliance, one of our founding, SAMHSA founding partners, was during an icebreaker shared the fact that she was wrestling now with the fact that as an executive director of a nonprofit serving children and youth in her community, that she went to sleep each night with the weight of the welfare and the well-being on her shoulders of her native youth. And it caused me some emotion because I felt like I was the only one as a child welfare director in my county that I held that whole burden for my 87,000 youth. But I suddenly realized that here were my partners in the private sector who shared the same burden. And it was liberating and bonding for us. So lots of other reasons that collaboration is important. In Placer County, we're a pretty conservative county, and so I don't often refer to the village being necessary to raise kids, but what we say in Placer County is that if you do need a village, it's really nice to have one. So with that, I'm going to yield to Jim, who's going to talk about money and how it helps us succeed, and then if we have time, we'll come back to some examples of where that's working for us.
Thank you, Richard. What we have on the slide right now is a mix or a listing of mental health fund sources that we bring to bear to serve our child welfare programs. We're in probably not a unique situation in the state, but we're a combined health and human services agency, and we're part of our county general fund. And the county's been very generous over the years in overfunding or overmatching both our mental health and our child welfare programs. Typically, we have a big county commitment to fund those programs, and at the end of every operating year, we seem to turn a few $1 million back as a department as a whole. So that includes our eligibility, our Medi-Cal food stamps, employment services, all our health programs. So what we have here is a list of programs, and I broke them out into the 3 primary service areas. We do have a children's shelter that's staffed by county staff. It's not a contracted facility, so that's the one at the very bottom there. One advantage to our structure in the general fund is we issue contracts to, for example, alcohol and drug and mental health providers, and it's irrespective of the population that they serve. So Richard's division can purchase mental health services through a contract with a local entity. At the same time, the adult system is doing that and purchasing crisis services. We have the same flexibility with a lot of our alcohol and drug contracts that aren't program specific like AB 109. On the next slide, we have a few examples, and we could probably take questions on those later. And the next slide. These are the goals of our fiscal integration. It's to improve access, and this really originates back in the 1980s when the county decided to go down this road and break down the barriers between different divisions and different service areas within the county. Because we're a system of care entity, we don't need MOUs with any other departments apart from our probation staff. So probation has an MOU, but community health partners are co-located in children's system of care without MOU. And of course we have alcohol and drug, mental health, and child welfare workers all working on the same team and within the same divisions. So we've eliminated a lot of barriers to working together. We went through a huge fiscal crisis in the last few years. The main impact on our programs was a significant hiring freeze. I think we went about 3 years without hiring anyone other than a psychiatrist. So it really kind of crimped the kind of service delivery model that we could pursue. It did force us to look more at outside entities, contracts, and with CPOs and for-profit providers. We use a uniform base or a database to authorize all their services, and this can range from supports to alcohol and drug treatment to mental health services with a network provider or with a contract provider. So all our workers have access to that system. Their support staff go in and do an eligibility review, and so they do a primary cut and identify potential funding sources at that level. After the fact, depending on the availability of funding, we can go back in and resort or revise some of those decisions and to maximize the funding that we draw down to pay for our services. And I think that was partly addressed in this last bullet point too. And of course, the decisions that we make feed our county general ledger system. We do mental health, we do alcohol and drug cost reports, we do the quarterly CECs in our social service programs. You know, there are disparities between claiming rules between Department of Mental Health, Alcohol and Drug, and the CEC. So we constantly wrestle with that and refine our approaches to make sure we're meeting our obligations in those areas.
Thanks, Jim. I threw the next slide in, which is a matrix of our Mental Health Services Act, because I think it's critical that we understand the extraordinary opportunity that Prop 63 presents to us to meet these particular needs, not just from a service and a capacity standpoint in each county, but structurally as an integrated agency. Because I, in my county, wear the hat of the children's mental health coordinator and the child welfare director, I had a prime spot at the table to lead the community conversation around how to use these dollars. So many of the services you see represented here, while they do not target child welfare recipients or children in my foster care system, we've been able to, with our community partners, to weave a significant matrix, $12 million worth of services in my county that really are touching the lives of those young people, whether they're in a kindergarten classroom or a pre-K or somewhere on a school site. They're getting prevention services that will, in essence, keep them out of the system of care, if that makes sense. And those conversations should be happening. I think every county is doing an update in the next year or so on their Mental Health Services Act. So if you're not seated at the table there, you should be looking for opportunities to leverage Prop 63 dollars to effectively serve kids. We're getting incredible years. We're getting a host of mental health, evidence-based mental health services, serving now, again, 15,000 families in Placer that were not served before. How am I doing on time? Am I okay? Okay. So let me quickly run through a couple of examples. Next slide, wraparound. We had, prior to 2003, about 110 children in group homes in both the dependency and delinquency systems. Let me say as a caveat before we talk about some of these outcomes, I'm mindful that many counties and communities in the state, in fact, most, have similar positive outcomes in the child welfare arena. What I would just suggest is that departing from the platform of integrated system of care allowed us to leverage the improvements in child welfare of the last decade in a little quicker way and a little more deep way, if that makes sense. And you'll see some of the evidence for that, I think. So we started off with 110 kids in group homes. Today we have about 60. And of course, the cost avoidance and savings relative to wraparound for the County Child Welfare Authority is significant, about $2 million a year in Placer County. We have a functional family therapy model. I should back up to wraparound. A few years ago, we realized that our drug court kids in dependency are also at risk of placement oftentimes, and so we're now serving our drug court almost universally with wraparound models, which has been very effective for our families. They love it. Our judges love it too. Functional family therapy has been built largely with this collaborative. Last year, we had 42 youth and families that were in care. One of those 42 required a higher level of care. So I think everybody knows about how effective functional family therapy can be. The Crisis Resolution Center is a fascinating program in our county. It's not just a respite center for teens where you can go to get 30 days of time out from your family because you're having challenges with your parents, but required of the families when they enter this public-privately funded partnership is that the family has to engage in functional family therapy. Additionally, there's a team that meets twice a week, including schools for the kids that are temporarily housed at the Crisis Resolution Center, and we think there's a cost avoidance of about $1.5 million. We basically leverage a $500,000 JJCPA grant, and we touch about 100 lives a year. There's a crisis response service that's located also in the Crisis Resolution Center. It's the gateway in. We effectively keep about 2,200 kids resourced in the community. They're not all in crisis, but it's a bit of a resource line as well. And the private provider, it's a group home agency in our county, they provide that as an in-kind partnership. That's one of the toys they bring into the sandbox, if you will. Really quickly on the delinquency side, the average daily population of our detention facility is down significantly. You can see, again, largely driven by some of the evidence-based services and the partnership that comes with wraparound. Next slide, the overall decline in formal cases, you can see about a 55% decline in just 4 years in delinquency pop in Placer County. My chief probation officer asked me every couple of months, what am I going to do with those empty beds? And then really quickly, some child welfare outcomes. And again, I want to emphasize this is not all due to integrated system of care. There are lots of reasons why these metrics are what they are, but we, again, think system of care has fostered much of our success over the years. So if I have just 1 or 2 more minutes, let me just speak to some of the system outcomes. The sandbox, by the way, is my favorite metaphor because we get to work with kids and youth every day, and if you think about the lessons you learned in early childhood, having to share sand in a confined space and learning to share toys. Some kids brought Tonka trucks that were fully loaded, right? All the bells and whistles. Other kids, myself included, I just grabbed grandma's ice cream scoop out of the pantry, and that's the toy I brought to my sandbox. But what I quickly discovered is that it could be a backhoe or a front loader or a stop sign or a satellite dish. Every toy has value, and that's why the conversation's important. A couple of the system outcomes, you heard Beth talk about parent-centered, family-centered care. In the last 18 months, we have effectively evolved our interagency management committee, which is our hard-to-place committee, into a community-centered process. We now have that process facilitated by a parent with lived experience. So when the family comes to us on the night before, it's a family member who's calling them on the phone to welcome them to that committee process, so they're not engaging with a government bureaucrat who's never walked in their shoes. They're being handheld again during that very challenging process by a parent with lived experience. She actually facilitates that large family team meeting thing that we do with hard-to-place kids. And so it really equalizes the power and changes the culture. I want to emphasize the importance of co-location. We have 4 or 5 agencies on contract. Jim mentioned they are co-located in our community, our county clinic sites with us. By co-locating them, we have done more to change the government culture, because these are persons who are living in our communities, and they're not trained professionals. And by them coming to our meetings and being in our break room together and contributing to our newsletter and being on our team with equal power, if you will, they've helped to change the way we as professional government folks do business. It's made us more welcoming, much more transparent. We speak a truly family-centered language now, although we have far to go. So I think with that, we'll wind up. And again, we're going to take questions afterwards. Is that right? Okay. All right. Thank you.
Yeah. So thank you very much.